Appendicitis. Appendicitis is defined as an inflammation of the inner lining of the vermiform appendix which can spread to its other parts. Appendicitis remains a clinical emergency and is one of the more common causes of acute abdominal pain. Appendicitis is caused by obstruction of the appendiceal lumen. The most common causes of luminal obstruction include lymphoid hyperplasia secondary to inflammatory bowel disease or infections, fecal stasis and fecalids, parasites, or, more rarely, foreign bodies and neoplasms. Appendiceal obstruction increases pressure within the lumen. This leads to continuous secretion of fluids and mucus from the mucosa and the stagnation of this material. At the same time, intestinal bacteria within the appendix multiply, leading to the recruitment of white blood cells, formation of pus and subsequent higher intraluminal pressure. The clinical presentation of appendicitis is quite inconsistent. Only 50% of the patients present with the classic history of anorexia and periumbilical pain followed by nausea, right lower quadrant, RLQ, pain, and vomiting. Other common features include abdominal pain, nausea, anorexia, vomiting, diarrhea or constipation. The abdominal pain in appendicitis typically begins as periumbilical or epigastric pain which then migrates to right lower quadrant. Patients usually lie down, flex their hips, and draw their knees up to reduce movements and to avoid worsening their pain. The duration of symptoms is less than 48 hours in approximately 80% of adults but tends to be longer in elderly persons and in those with perforation. The physical findings of appendicitis includes rebound tenderness, pain on percussion, rigidity, and guarding. Tenderness is most common in right lower quadrant, in patients with situs inversus or in those with a long appendix that extends to left lower quadrant. Left lower quadrant tenderness is usually obtained. Male infants and children occasionally present with an inflamed hemiscrotum. In pregnant women, right lower quadrant pain and tenderness dominate in the first trimester, but in the latter half of pregnancy, right upper quadrant, RUQ, or right flank pain may occur. Laboratory tests for appendicitis do not have findings specific for appendicitis, but they may be helpful to confirm diagnosis in patients with an atypical presentation. Leukocytosis with neutrophilia is a common finding in patients with appendicitis. Leukocyte count is not useful in infants and elderly patients and pregnant women. CRP levels of more than 1 mg per deciliter are common in patients with appendicitis. Very high levels of CRP in patients with appendicitis indicate gangrenous evolution of the disease, especially if it is associated with leukocytosis and neutrophilia. In adults who have had symptoms for longer than 24 hours, a normal CRP level has a negative predictive value of 97 to 100% for appendicitis. HIAA levels increase significantly in acute appendicitis and decrease when the inflammation shifts to necrosis of the appendix. Therefore, such decrease could be an early warning sign of perforation of the appendix. CT scanning with oral contrast medium or rectal gastrograph in enema has become the most important imaging study for evaluating atypical presentations of appendicitis. Low-dose abdominal CT may be preferable for diagnosing children. Ultrasonography may offer a safer alternative as a primary diagnostic tool for appendicitis in most cases. American College of Emergency Physicians recommend ultrasonography for confirmation, but not exclusion, of acute appendicitis. Vaginal ultrasonography alone or in combination with transabdominal scan may be useful to determine the diagnosis in women of childbearing age. Few other tests used for appendicitis diagnosis include the kidneys, ureters, bladder radiographs, barium enema study, radionuclide scanning and MRI. Emergency management of appendicitis. Establish 4-axis and administer aggressive crystalloid therapy to patients with clinical signs of dehydration or septicemia. Keep patients with suspected appendicitis nil per oral. Administer parenteral analgesic and antibiotic as needed for patient comfort. Appendectomy remains the only curative treatment of appendicitis, but management of patients with an appendiceal mass can usually be divided into the following 3 treatment categories as described. Antibiotic prophylaxis should be administered before every appendectomy. Broad-spectrum gram-negative and anaerobic coverage is indicated. Sulfatinib and cefoxitin are the best choices of antibiotics. In penicillin-allergic patients, carbapenems are a good option. Pregnant patients should receive pregnancy category A or B antibiotics. Antibiotic treatment may be stopped when the patient becomes afebrile and the WBC count normalizes.